CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good afternoon, everybody. It's wonderful to see everyone here. Please continue to get your lunch, make yourself comfortable while we get ourselves oriented to this presentation that we've all been looking forward to from Dr. Anita Ho. My name is Amy Salmon. I am the Associate Director of the Center for Health Evaluation and Outcome Sciences, and it's my great pleasure to welcome you here today. I'd like to, before we begin, acknowledge with gratitude that we are meeting today on the traditional, ancestral, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh First Nations. So, without further ado, Dr. Anita Ho will be speaking to us today on the topic of from AI for degenerative conditions to generative AI, ethical considerations. Dr. Ho is a clinical associate professor at the Center for Applied Ethics at UBC, also an associate professor at the University of California, San Francisco's Bioethics program, and a scientist at the Center for Health Evaluation and Outcome Sciences, where we've been pleased to have her among our number for quite some time and are delighted to have the opportunity to welcome her back to Vancouver. Dr. Ho is an international scholar with more than 80 articles and book chapters whose current research focuses on ethical dimensions of utilizing artificial intelligence in healthcare, research design ethics, supportive decision-making, and end-of-life care decisions. Her new book, Live Like No One Is Watching, Relational Autonomy in the Age of Artificial Intelligence and Health Monitoring, was published by Oxford University Press only just last month in May of 2023. So please join me in welcoming Dr. Ho.
Thank you so much, Dr. Salmon. Really a great pleasure and my gratitude to be returning to the traditional, ancestral, and unceded homelands of the Coast Salish people. And I know that there may be others who are on the call today that are coming from other territories as well. So welcome, everyone. I also have been having the privilege to be living in San Francisco and Santa Rosa and working there as well. San Francisco is the unceded ancestral homeland of the Ramaytush Ohlone people. So I want to also share my gratitude, as well as in Santa Rosa, which is the homeland of the Pomo and Coast Miwok nations. So I sometimes think that I really am in the best of all worlds in terms of having beautiful lands that I'm playing in, learning from, and working in as well. So my gratitude to all. So I also want to acknowledge the funding for some of the projects I've been working on. Have been generously supported by the Canadian Institutes of Health Research, CIHR, as well as Emerson Collective. So part of the work I did for the book that Amy mentioned earlier has been a project I was working when I was a fellow for Emerson Collective. I also want to give gratitude to Oxford University Press that published this book, which really kept me grounded in making sure that I actually finished this project. And today what I'm focusing on would be partly an empirical research project that I've been conducting with Dr. Martin McEwen, Dr. Itai Bafli, as well as Ravneet Mahal on using AI for degenerative conditions, particularly Parkinson's disease. So I'm going to have a two-part presentation today. I'm going to first focus on the empirical research project that we have been working on in relation to Parkinson's. So that's a project that from the embedded ethics perspective, the empirical data collection aspects have been completed. We are still doing data analysis, though we have already submitted one article that has been under review, is revised and resubmit. So we are going to be submitting our revision pretty soon. So hopefully that will come out soon. And then what I will do is I will transition from that work in terms of some of the lessons that we learned from that project to some of the work that I'm beginning now on thinking about generative AI. And so this will be also part of my call for those who are here in person, as well as those who are online, to see whether there may be other collaboration opportunities as well. I would definitely welcome the opportunities to work with others, particularly if we are using different methodologies. So to give you a bit of background in terms of the Parkinson's project that we have been working on. So as many of you would know, Parkinson's disease is a progressive multi-system neurodegenerative disorder. Currently, there's no cure for this condition. And patients who have Parkinson's disease often will show various types of motor signs, from slowness to rigidity in the movement. They may have also balance loss as they progress in their conditions, and the gait might freeze as well. Unfortunately, at least in Canada, patients often don't get to see the neurologist very frequently. Sometimes it may be only once a year. So what that often means is that whatever the progression may be happening during that time, patients won't be able to find out until much later. And we may not be able to tweak medication for people who are living with Parkinson's until a much later time. So because there is no cure, often people living with Parkinson's really want to have much more frequent at least monitoring to see if they should actually change any of their lifestyle, diet, and so on and so forth. There are currently some sensors and other kinds of monitoring cameras that may be able to help people to track their condition or the progression, but they also have various kinds of disadvantages. For example, patients' worn kind of data sensors may be cumbersome for people who have to use them. They may or may not remember to put them on or turn them on. There are also different privacy considerations as well. Some CCTV type of cameras may also be capturing people's faces and so on, and the specific environment that may have various kinds of privacy considerations. So our CHR-funded project has been looking at whether automated computer vision monitoring can be a good alternative that could be more privacy congruent and also give people the kind of information that may help them in terms of the progression and so on. So some of you are probably familiar with how computer vision classification works. So basically the computer can recognize different objects and classify what the objects might be. They can also perhaps also count as well in terms of how many number-wise what objects have appeared however many times. So the idea is really help you to have various kinds of computer vision classifications that can distinguish one object from another, one image from another. And computer vision has been much more used in medicine and in healthcare. And so that's part of what our project has been looking at. Our project is really looking at whether we can use computer vision to monitor people living with Parkinson's. So it really tries to track people's body movement, the gait, the balance, the mobility, and hopefully also their mood. So what that means is that it can give clinicians a better sense in terms of how the person may be acting, how the person may be responding at various times. And as I mentioned, because people are only there sometimes for a very brief period of time for their clinical consultation and also for very infrequent kind of visits. So the point is that basically then you can have longitudinal information so that the clinician can use that information accordingly. And the idea too is also that the computer vision the platform will not be sending the raw data outside of the system, so that hopefully it could be more privacy compliant as well. My part, or our part, and that I'm presenting today, is really only focusing on the ethics study and looking at how do people living with Parkinson's disease, their family members, and healthcare providers who are providing care to people with Parkinson's see the use of AI to track and predict disease progression. We also wanted to explore participants' views on the comparative benefits and burdens of using an automated computer vision tool for monitoring. Even though at this point, this tool is still in only research stage, and we don't actually know whether people can actually use it at home, participants mostly talked about the implications, ethical implications of using such technology at home. In particular, our patient population and family members were really interested in possibly having various kinds of technologies that can be used at home. And this came out even more when we were doing some of the focus groups during COVID pandemic, especially because people were not able to see their neurologists. Our ultimate goal is really to inform technology development and implementation based on how stakeholders view these technologies. So this is a qualitative research study We conducted 4 focus groups in total of 31 participants, and 23 of them were people living with Parkinson's disease, and 8 of them were family members. We also used semi-structured interviews with neurologists and other healthcare providers who were part of those team care teams for people living with Parkinson's. And then we use inductive thematic analysis to look at what each particular group talked about, and also do some kind of comparative analysis to see whether, for example, people living with Parkinson's gave us similar ideas in comparison to healthcare providers and to family members. What was really interesting to us was that, and this came out in my book as well, as a bioethicist, I look a lot at how people make healthcare decisions, research decisions, and technology adoption decisions. But what we really find is that people don't make decisions just about one technology, one algorithm, and one research project. They often really think about it in relation to other kinds of considerations. So what we really found was that there are multi-layer concerns that people had. They have individual concerns and considerations that they think about when they decide whether to adopt certain technologies, but they also have relational and interpersonal considerations as well. And intersecting with that were other professional and institutional considerations, and then much broader societal resource allocation types of considerations. And I'll walk through each of them briefly. So at the more individual and personal level, our participants talked about some of the perceived benefits and concerns that they have. So most of the people living with Parkinson's talked about how they really hope or believe that the use of the technology can help to promote their understanding of their conditions. So that they think that if they have that information, they would be more informed, and hopefully this can also promote those kinds of personalized treatment options as well. They also think that because this is a neurodegenerative condition, their cognitive capacity may also get lower as the condition progresses, that this may help to also lower their own burden of tracking their conditions. Sometimes they may not remember everything that has gone on, especially because there are long time lapses between different visits. They also think that this may also be an empowering tool for them that can help them to really track their own safety, especially if you have computer monitoring technology that can actually give you alerts and to say you should hold on to the railing, or maybe today is not a good day to drive. So people felt that that may also help to promote their self-efficacy if they have these types of monitoring, assuming that these technologies work well and are accurate. Our participants did have also concerns about whether some of these technologies, especially if they are integrated into the home setting, may in some ways exacerbate hallucination and paranoia, particularly due to some of the medications that people with Parkinson's are already taking. There also were concerns, particularly from the healthcare providers, in terms of whether the information given by these technologies are really of high value. Sometimes you may have noise instead of actually really actionable information. The people living with the groups of people living with Parkinson's disease also were a bit concerned about how some of the monitoring may impose the illness identity on people, even though people with Parkinson's may have very diverse symptoms or severity. But when you think about tracking people, that is assuming that they have certain level of vulnerability, that they might be all in a very homogeneous kind of disease state. Of course, they also raise questions about privacy and who may have access to the data, and which I'll come back to as well. Some of these concerns also intersected with participants' concerns about other relational or interpersonal considerations. Many of the people living with Parkinson's disease said that, well, actually, especially as their cognitive and physical conditions decline, families would be part of the team, so they trust the family to have the information from the computer vision monitoring. But interestingly, they also were a little bit worried in terms of what families may use the data to do to them, particularly in cases where families may be even more risk averse than people living with Parkinson's. So the person living with Parkinson's may have their embodied experience to tell them that they feel okay, But especially if you have AI predictive monitoring that actually shows you to be more at risk, even though you feel okay, how do you actually reconcile that with what the machine may be saying and what your families may worry about? So they raise concerns about whether that would change family care and other kinds of power dynamics. One issue that also came up from both the people living with Parkinson's and also healthcare providers is whether some of these technologies may also change the frequency of even family visits. So on the one hand, if the machine is showing that the person living with Parkinson's is doing just fine, would they just use that as a way to say, then we don't have to see grandma, grandpa, and so on. But at the same time, it may also get family members, especially family caregivers, to be really nervous and keep checking on the person if you have a very sensitive device. Related to the in-person, particularly familial care concerns, people also talked about interprofessional concerns as well. And this was in relation to how there may be, on the one hand, good to have longitudinal information to enhance therapeutic encounters and care decisions, especially since then the clinicians can not just rely on what they see in those 15 minutes that you're in the consultation room, they can look at more longitudinal information. Some people also said that, well, if I can actually show that I have been not feeling well, and then this machine can back up my testimony, I may also have more credibility when I talk to my physicians. But at the same time, all the participants did also show concern about how they don't really know, for example, whether they want to actually get the information directly from the machine, directly from the algorithm, or they want clinicians to be the ones to deliver that information. On the one hand, so there's some parallel with like genetic testing as well. People talked about how like with genetic tests, you don't want to just get that information, especially if it's bad news. But as I mentioned earlier, there are already infrequent visits to neurologists. So if it is the case that every time there's some kind of alert, if the idea is to somehow to help to supplement or possibly even replace in some visits, would this actually in some ways, ironically, also add more visits that may or may not be necessary? Participants also talked about divergent reports between what the AI may show and what patients may remember or report as well. Even though some of our healthcare provider participants also said that we shouldn't have this AI exceptionalism because patients often have different reports than what lab results may show anyway. So this may not really necessarily be a concern, but because in the rhetoric and promotion of AI, there's often this assumption of objectivity and accuracy, and there were questions that came up in terms of whether people living with Parkinson's may have a harder time to dispute what is coming from that. And in fact, even healthcare providers may have the same concern. If they are trying to assure their patients, but the patient said, well, but the platform is telling me something different, how do we actually reconcile that? Will there be liability concerns as well if the healthcare provider does not actually go along with what the AI is saying? So this also intersects with system and societal concerns. Many of the participants said that, well, if these technologies, including computer vision technologies, are accurate and can be clinically useful, they can hopefully be good societal investment, particularly if they can give us better information access to those who may be living in more rural areas and underserved areas. At the same time, this can only help people who have been underserved if we have the infrastructure to begin with. So because many people who are living in some of these areas have already been lacking access, so this may actually not be really helping them if we have no infrastructure for clinics and also no infrastructures for example, IT support. So in some ways, and this may actually only benefit those who already have adequate access. So it may still, leave the inequity untouched, or perhaps even exacerbate some of the inequities. There were also concerns in terms of who will own the data and who can share or sell the data. This concern came up in particular when people with Parkinson's disease talked about how we're now living in more and more of a surveillance culture. So we're watched by everything, whether it's mobile, other kinds of cameras outside, and also when we think about various kinds of monitoring. Home monitoring, even from other companies that are not specifically talking about healthcare, may be merged. In some ways, it could be a good thing for big data that supposedly would get to be more and more precise in terms of our preferences, our lifestyles, behavior, and various kinds of histories. But at the same time, there's certainly questions in terms of who then will have access to all the data that we may have no control over after that. So I think that in general, basically what we found was that people really thought about how these technologies could be helpful at an individual level if they are accurate. But there certainly were various kinds of intersecting questions around how people thought about their illness identity. The participants that we had, some of them were actually quite young, in the 40s to all the way to the 80s. And people really thought that, depending on where you're at, you may or may not want some of the monitoring. But once we start assuming that people would want monitoring, it may be the case that we would just have to accept that we will always be surveilled from here on. So that may affect how people also think about what it means to be living at home or not being in a clinical environment. On the one hand, people seem to really think that it would be good for family members to have that information as well. But there are also questions in terms of whether there may be changing power dynamics when family members may have a lot more information about the person that they didn't have before. And I can say more about that if you are interested. It was interesting, too, in terms of whether people thought that this would help to enhance therapeutic relationships, especially because all the participant groups were still at this point quite skeptical in terms of what the clinical value of the predictive information might be. And with that in mind, then people were really concerned about the data ownership and governance, especially in the very vastly expanding technological realm. And that many technologies have been promoted as being helpful, even when we don't actually know if they have been really fully tested, especially for different populations. So those were the main lessons that came up from this project. And what I'm now going to then pivot is to then think about how may some of the lessons that we have learned from this inform other kinds of work that we are thinking about in AI. And so this, as I mentioned earlier, this project was finished already from the data collection perspective. We're still doing some data analysis, but as generative AI is becoming more and more popular, or at least more and more people are interested in generative AI, then what I want to do in the next phase of my research is to really look at what may be some implications, what are some lessons that we can take, and then to perhaps also test and see whether people think the same way about generative AI. And especially partly because there's a lot of press that has been coming out in terms of generative AI, in terms of how it can be used, where it can be used, and how it could be hopefully serving different population groups. So you can see in this slide too that many different health systems have been really trying to see if they can somehow utilize various kinds of generative AI programs or models to help them to predict, for example, in the left top corner, to predict a readmission rate within 30 days, in hospital mortality, whether insurance claims may be denied. Of course, this was in the US context, and whether patients may have longer length of stay. So the idea is that if you have more and more unstructured data in the clinical setting, particularly with clinical notes and so on, this is like a vast treasure trove that we can really use to see whether there may be other information that we have not had before. Google Cloud is also partnering with one of the biggest or most important organizations in the US, the Mayo Clinic, as it also tries to expand the use of generative AI to help different organizations to build their own or adapt different types of AI chatbots as well. There are also reports of many physicians now that they have tried ChatGPT or other kinds of models and chat models, that they're using these algorithms and these platforms to help them actually write scripts to patients, or to use them as teaching tools to think about bedside manner, things to say. Perhaps ChatGPT can help you to say things in much more, quote, empathetic kinds of ways. So in terms of generative AI, in an extremely and perhaps overly simplified ways of looking at it, this is really looking at massive data sets. So large language models probably is the one that people have heard more about in recent months because of ChatGPT. So you can have patient data of various sorts, whether it's genomic data, lab data, patients' own messages to the clinicians, questions that they have, emails they have, or other kinds of clinical notes as well. There can also be research data that people can get from clinical trials. And of course, more and more so, people may have wearable and sensor data that are patient-generated. My partner, to my dismay, bought one of those. He didn't care as much about privacy as I do. So these massive data sets, and can, particularly in relation to large language models, and which I will focus on a bit more today, can really learn into the rules of language to then recognize, predict, and translate and generate new data and new language. And so there are hopes, and when I was showing the last slide as well, but there are hopes that with large language models and large data sets that we may be able to actually use these models to help come up with diagnoses, to send alerts, and also perhaps give various kinds of recommendations to patients and others. So what I want to focus on today, which is a topic that I just started working on now, is whether we think that the use of mental health chatbots using generative AI would be a good, not just clinical or technological tool, but also an ethical tool. So many of you probably have heard already that even just within the first year of the COVID pandemic, that there was a huge increase in terms of prevalence of anxiety and depression. Worldwide, that number has gone up by 25%, according to the World Health Organization. And that number, may fluctuate, and now some people may have, quote unquote, adapted to the new environment, but many of the burnout, stress, and so on persists. And because of the increasing prevalence, and also just various kinds of situations happening, and with the workforce demand as well, that there's now more and more of an increasing demand, but less and less availability, which means very long waits for people who want to have mental health visits. And people with mental illnesses also have to have very long waits to see a clinician, particularly for specialists. As a result, there have been surging interest in using AI chatbots that are powered by large language models to supplement or possibly even replace professional care. So I generally don't name products. And so many of these products are claiming that they actually can give clinically tested tools and tactics for people to try, that hopefully that can really change their mindset so that they may not even require or need any kind of professional help. Now, there is a distinction that I haven't really drawn here carefully yet, but this is certainly what I'm going to be looking at in my research as well. Mental well-being versus mental illnesses. Okay, so I would just at least flag that part. But these are tools more and more marketed as ways that can also help clinicians as well, that there may be patients that have lesser or less serious needs, but perhaps they may be able to use some of these tools in between visits, and only if these chatbots may require or may suggest professional visits that patients would make appointments. As I mentioned in the Parkinson study that we looked at, or that we came up with a multi-level framework and to think through some of these ethical considerations. So I want to see is whether some of the multiple levels also apply for generative AI. So what I'm going to look at is whether the impact on how people, there may be impact on how people will generate, share, and seek mental health information. Whether these technologies may also change the way that we may monitor our own mental well-being, or how people may promote the well-being based on chatbot suggestions, and also whether that will affect the way that they actually seek mental health advice. for example, changing from going to quote unquote experts or professionals to using some of these algorithms. I also have a very keen interest in trying to see whether the on-demand type of engagement that are being promoted by these technologies, especially when people can bypass their social and professional networks, will have impact on interpersonal as well as therapeutic relationships. And I think that this may be particularly interesting and important to consider when we're talking about mental health and mental illnesses. I also want to look at whether there may be impact on institutional workflow, professional workflow, because even though we often think that EMR or other kinds of technologies can help clinicians, there are also many studies that show that actually it reduces in-person time, partly because clinicians are now spending even more time in front of the computers and the monitors. So there would be questions in terms of also whether there may be broader systemic and justice considerations as well, in terms of what options people may have if they do have various kinds of healthcare needs. So can they still access professionals if the model is becoming more and more of a virtual type of care, particularly using predictive analytics? As I mentioned before, that there may be individual, relational, or interpersonal, professional, and institutional, as well as societal considerations. So those are the questions that I'm thinking about right now. At the individual level, there are certainly questions in terms of whether or how we may want to balance the potential but really uncertain benefits that these generative AI model may offer and the burdens that may come from them. This may be particularly the case for people who are lacking healthcare access. There's some studies that there was a scoping review that show that people who are more likely to access the use of various health apps to diagnose or to self-monitor are ones who have stigmatizing conditions or maybe more socially marginalized already. So it's also, I think, an ethical and a justice consideration, especially when we don't know for sure that these applications are actually having good clinical value. So if people don't have access to professional care or not enough access, and they only have access to lower value types of applications, then they may be exacerbating various kinds of health outcomes and inequities. There's definitely still concerns in terms of what may be some of the constraints, systemic constraints and technological realities at this point. How LLMs are being trained, and what data sets are being used for that, and what context are we actually using them in may often lead to inaccurate responses or answers. And I'll come back to this in a bit as well. So that's why there may be situations where you have heard about AI hallucination. The chatbots and generative AI can often give you really good information in general or guesses, but they may have never happened. Some of you may have heard about a lawyer in the US that filed a brief using ChatGPT, and then they realized that actually some of the cases sound great, except that they never existed. So unless you still have humans in the loop to do all the checking, you would not realize. Now, some people thought that, well, this is silly or stupid for the lawyer to not be checking. But at the same time, I also think that this is actually waiting to happen when many of these technologies have been really promoted as if they are accurate. So having those concerns may also raise other kinds of interpersonal questions, especially when we think about using generative AI tools for mental health, partly because there may be questions in terms of whether these tools actually can be really good replacement or supplement for in-person kind of interactions. But I also have the ethical question, even philosophical question, in terms of how more interactions with these technologies may actually change the way we think about what interpersonal relationships should be like. So in particular, one thing that concerns me is, particularly in relation to mental health, is how we have to often think about personal boundaries as well. When you have 24/7 availability of the chatbot, you may now start to think that all those humans with flaws who don't want to listen to you are now seemingly even more annoying to you, right? Because they're not answering all your questions at any time of the day, and they will keep going on and on and on. So because AI does not experience any kind of fatigue or distress, they may actually also get people to be going over and over in the same loop. Right? So in some ways, I worry about whether it actually can exacerbate various kinds of concerns or mental health concerns. So there may be questions in relation to the interpersonal kind of relationships. Many have said that, for example, if you look at teenagers' mental health, the interaction with social media actually has made them more anxious about various kinds of situations, and perhaps made them even more socially awkward when they have interactions with real humans. So there may be questions in terms of whether more, for mental health purposes, more interactions that supposedly will help to, for example, ease loneliness, distress, depression, and so on, may ironically have opposite effect. And I also have questions in terms of various kinds of interprofessional considerations. Again, when we think about psychologists, psychiatrists, or other therapists who may see patients with various kinds of mental health concerns, generally speaking, you have the therapists or counselors who are not only looking at what the patient may be telling them, they also look at nonverbal cues, and in many cases, you also ask follow-up questions. There may be times it's not so much that you don't trust the person who's telling you the information, but you may have reason to think that you have to ask follow-up questions. Generative AI at this point really give you more scripted or predicted sentences that will come from what the person has told you, but it really takes that at face value. So in many ways, they would not be able to read between the lines. And so when a lot of the mental health diagnoses and considerations really have to think about the nonverbal cues and other kinds of follow-up questions, but there may be concerns in terms of whether the on-demand chatbots, one does not actually give you boundaries, but at the same time gives you also worse or less accurate information. Again, remember that for people who are seeking mental health care, they generally would have to go to the clinicians at a specific time, at a specific location, with specific types of questions. The therapist can give them also feedback in terms of what may not be within the bounds of those discussions. Chatbots, on the other hand, right now are not doing that. So of course, there may be questions in terms of whether chatbots for these particular purposes could in the end also change as well or improve as well. It does raise various questions in terms of also who can have the expertise and authority to provide these types of advice. Licensed professionals versus many chatbots that currently have been mostly developed by technologists who may or may not have any kind of medical training. There are also questions in terms of whether simulated empathy, which has been a big selling point for many of the mental health chatbots, may actually be disguised as good quality information when there may still be questions about whether they're accurate. A recently published paper, which I was surprised it got published, but anyway, that compared physicians' text responses on Reddit. I don't even know who uses Reddit, but they compare what physicians would write on the Reddit responses to patients' inquiries about various kinds of medical issues to what ChatGPT would say if you put exactly the same question on there. And these raters, who were healthcare professionals themselves, rated ChatGPT to be of much higher quality and much more empathetic compared to clinicians. Even though I thought methodologically it was very problematic to compare what physicians may write off the clock on Reddit, and especially for people you have no therapeutic relationship with, because everybody is anonymous, to what ChatGPT might say. But I even wondered whether the evaluators also mistook length of responses and some of those simulated empathetic responses to be good quality responses. So I even thought whether ChatGPT was Canadian, because when I did ChatGPT, it would keep apologizing and apologizing and apologizing. When I would question ChatGPT more. So intersecting with the interprofessional considerations are also institutional questions. Because you may have health authorities or clinics or hospitals that think that this may be a way to follow up with patients. This can help to improve workflow and possibly even staffing. If you have people who don't have to now always follow up with the patients, and then you can use the chatbots. So there will certainly be impact or implications on that. There are questions in terms of whether the ChatGPT type of platforms can also improve clinicians' burnout, or improve in the sense of like reduce the burnout, especially given that during the pandemic, there have been a big increase in terms of patients' messages to clinicians. And so if the chatbots can write up some of the responses for you already, and then you may just use that to, for example, tweak your responses to patients, that may help to reduce burnout, or that, at least that's the idea. But there certainly are questions in terms of whose responsibility it would be to ensure that these chatbots are clinically accurate and valuable, particularly if clinics and hospitals or health authorities may want to deploy them to supplement professional care. Currently, there's very little proof at all that these chatbots can actually help for the long term. Sometimes people may feel less lonely at the time that they're using it, but whether that actually means that in the longer term they have even less in-person interaction and that may have implications is still a question. And this then raises other kinds of broader systemic questions that I want to look at. At least from our Parkinson's disease study, people really talked about how their uptake or their willingness of taking on these technologies may depend on other kinds of system considerations. So it may, for example, depend on where you live, whether you're close to any medical centers, whether you would be able to actually get more frequent visits with your clinicians. So the resource allocation situation in the broader healthcare system would make a difference in terms of whether people actually want to use it. And of course, people were very concerned in the Parkinson study about the personal privacy and data privacy. So there are questions also in terms of who may actually have access to some of this information. Whether the device companies may have the information, which means that they own it and can share and sell them to other third parties. There are also questions right now in generative AI, whether particularly the language models perform better when the users are English speakers and native English speakers compared to people who may be using other languages. So you can imagine that people who might be using the chatbots, especially if they are not first language speakers, that they may be misdiagnosed in some of these cases. So far right now, it especially is for the non-Latin scripts that generative AI has more problems with. So if that's the case, then you can also imagine situations where people who may not be English speakers, there will also be the equity concern as well. There may also be concerns in terms of whether, especially with the, since I'm now in the Silicon Valley as well, there may be questions in terms of whether the excitement of technologies will get people to invest more in AI, particularly generative AI, and in some ways then, not think so much about the in-person kind of visits and in therapists. So how do we actually navigate that? Especially there may be people who do want to continue and would need inpatient or in-person types of monitoring and consultation. And as a philosopher and ethics person by training, I'm also very concerned or want to think more about the shifting epistemic and economic power as we think more and more about using generative AI. Historically, in bioethics, particularly when we think about mental health, therapeutic relationships, there have been more concerns about paternalism from physicians or clinicians towards patients or people who may be have various kinds of concerns. But now, some people think that the use of AI, particularly things that may be more direct-to-consumer AI, may equalize that power dynamic if people have all the information on their wrist, in their phone, and at home. But I do have questions in terms of whether that historical concern of that power dynamic in therapeutic relationships may actually now be translating more towards the unfettered power of tech companies, but are now actually amassing a lot more information and a lot more data about people than they ever thought would be imaginable. So I think that when we think about some of these issues, it's not really just an individual consideration, that we really have to think more about how, even when people decide whether to buy, the wrist devices or the phone devices, that it's not just about one decision or one application. I couldn't even park at the airport without downloading an app. Actually, you could, but they make it so difficult that you would just relent, right? So, but of course, they would say you have consented to it. And I think that we actually really have to look at much, much bigger in terms of the social and structural framework. And that may be really determining and predetermining how people make those decisions, how they may approach what it means to get healthcare, how they approach their illness experiences and identity, and how this may change the social and therapeutic relationships. Certainly, there will be also impact on institutional practices, many of which will be very welcomed. But at the same time, we can't just look at specifically how this may improve, but also what may be some of the costs that come with it, so that we can really look at the cost-benefit analyses. And I do think that this will also be a really good time, a good opportunity for us to really think also more about professional training in terms of how we need to prepare healthcare providers who will probably now be getting even more messages from patients because patients are seeing what their devices and various platforms are telling them. So how can they advise their patients accordingly and keep good therapeutic relationships, especially when there may be disputes about these recommendations? So what I'm hoping is to look at using, again, a multi-level framework to see whether that can help us to really address these complex and intersecting individual, relational, and socio-systemic contexts within which people may be using or doing research on or receiving information from generative AI. So on that note, I'm exactly 10 minutes from it. Thank you.